Good morning, PT on Ice Daily Show. How are you? PT on Ice Daily Show is brought to you by the Institute of Clinical Excellence. And my name is Dr. Lindsay Huey, lead faculty for extremity management, along with Eric Chaconis and Mark Gallant. And I am delighted to be with you here on a Clinical Tuesday. I hope everyone's morning is off to a fabulous start. Today, I'm going to be speaking with you about how to promote anti-fragility in our humans that we're treating with NEOA. And we're going to discuss kind of those top three strategies to really annihilate vulnerability in this population of patients. Before, though, we dive into that discussion, one that I'm super passionate about, I want to just tell you about some upcoming courses extremity management has. So we have a ton of courses in the first quarter that I'd love to share with you, and I'd love to see you out on the road. So coming up in March 26th, 27th, we'll be in Nebraska, North Platte. In fact, I'll be with Megan Daly and Lauren from Onward Denver. So all three ladies will be on the road, and we'd love you to join us. And then Mark Gallant will be in New York, March 26th, 27th. And then I'm going to be headed to some warm parts of the country. I'll be going to Santa Rosa, California, April 9th and 10th. Please come to wine country with me and learn about best management for extremity. Good morning, all the waves. I'm loving them. Good morning, Ben. Those South DPT students. I got to give a shout out, and everyone else, good morning. Also, I will be in Bradenton Beach. Hopefully, I'm pronouncing that correctly, but basically just outside of Sarasota, Florida, April 23rd, 24th. That it has a limited number of seats, 12 to be exact. So if you're on the fence, please come join me and sign up quickly so that those spots don't fill if you're thinking about it and you're in that southern Florida area. And then really courses, I could just keep going, but they continue. Mark will be in Wisconsin May 14th. There are lots of courses just coming up. So please check extremity management out on ptonice.com to learn about a course near you, because we are all over the map this year and really thankful to be there and being able to join you all in multiple places. So diving into today's topic. So we all treat NEOA, right? It's one of the most prevalent conditions that we see. There are over 250 million people affected by NEOA worldwide. And, just to get that clinical picture in mind, it's that person that comes in with complaints of morning stiffness, some crepitus in the knee. They have had knee pain for a long time, and it's always associated with functional activities that are really important to them, like just walking, stair climbing, squatting. And then they often objectively demonstrate that flex knee posture gait, some quad weakness, some proximal hip weakness. And again, functionally, when you test them, it's that squat and stair climbing that tend to bother them. And like I said, we're seeing these patients almost every day seeing these type of patients every day in the clinic. And then we're seeing them out in the community, that characteristic knee flex posture, and possibly even in our own family, we're seeing these individuals. And we just have a ton of evidence, over 50 plus RCTs that really demonstrate the powerful effects of exercise on knee OA that really power any NSAIDs, Tylenol regimen, surgery, no matter the severity of knee OA. We see exercise and physical activity being superior in this care. And this is really our wheelhouse. And so I really think that we can do a better job to impact here. And a lot of it, the inspiration from my talk this morning comes from a clinical commentary from 2018 out of JOSPT by Skull et al. And friends. And they really take a deep dive into why both knee and hip OA are still a problem in our population. And so if that's a good reference to look to if you want to know more about what I'm talking about this morning. So if we know the powerful benefits and we have RCT level studies saying how amazing exercise is, not only for the body, but for mental fortitude of our patients. Why is this a continued problem? And so it's hard because with increased pain comes decreased activity. And when you have decreased activity comes decreased capacity. And then the sequela of chronic disease continues, right? And it becomes this cyclic problem. Physical inactivity is both a cause and consequence of knee OA. And we have increasing obesity and inactivity as a result. And so what can we do as PTs? Three things. Three things that I really want us to be very intentional about in this population that we can't miss a beat with. The first one, we must advocate hitting those physical activity guidelines. At least 30 to 60 minutes of activity 5 days a week. The WHO actually recently even increased this in 2020 that it should be at least 150 minutes to 300 minutes of moderate intensity aerobic physical activity. And for people that are hurting and in pain, that seems like a really lofty, far out goal. But it's our job to really not only advocate for these physical activity guidelines, but really make it physical activity accessible to our patients. And we have the great experience and opportunity to know how to grade activity and exercise. That 30 minutes, have them achieve that in 6 bouts of 5 minutes throughout the day, right? Meet them where they're at and then gradually build up their tolerance. The anti-inflammatory effects of hitting the physical activity guidelines cannot go under addressed or unnoticed. I think we do a great job in the exercise piece addressing impairments of strength and range of motion in the clinic, but that conversation about hitting the physical activity guidelines, I think we kind of misfire there, right? Or we even probably have some doubts ourselves. The patient that's barely walking in, limping in with the antalgic pattern, you're thinking in your head, there's no way they're going to meet these guidelines. Well, we have to figure out a way to help them, empower them to meet the guidelines, because that's the ticket: exercise and physical activity to really helping dampen inflammation, dampen pain, and then improve overall tolerance to activity. Physical activity, exercise is medicine in this population specifically. And I know PTs listening and future PTs, SBTs that are on this call, that you're passionate about that and helping people. So I know I'm kind of preaching to the choir on that one, but that importance of getting them to that point where they can meet the guidelines, we can't miss that. Second, exercise, our wheelhouse. Exercise that addresses impairments and that modulates symptoms. So, giving exercise that helps improve range of motion, reduce pain, and that helps improve strength. In particular, we know that quadriceps, we just had a great 2022 study come out about the importance of quad strengthening in knee OA. And then we also need our hips strong. And, to learn more about those ideal or favorite exercises for treating knee OA, please come to an extremity management course, because we really dive deep about kind of our go-to exercises and dosage and what that looks like. But what I want to, because I want you to come to our course. I know that again, you know this, right? We treat impairments. That's what we do. I think we just tend to focus on the exercise bucket, though, when we see patients. We tend to miss that physical activity guideline bucket. And then in the exercise bucket that I'm speaking to right now, I think we might underdose here. Dose and duration of sessions matters. We might have the best program that addresses strength and range of motion impairments, but the patient that only tries it for a couple weeks, that's not enough. And even 4 weeks is not enough. That ideal dosage, when you look at that clinical commentary out of JOSPT, is it's ideally 12 sessions over a 6-week period. That is a necessity when we're thinking about overall duration of care and giving, physical therapy a try. Think about that patient that says, "Oh, I tried physical therapy," right? And when you really dive deep into what that means, they looked up some exercises online, or their doctor gave them some exercises, 4 or 5. They tried it for a couple weeks, it hurt, so they kind of abandoned ship, right? And they tried conservative care. Well, that's unacceptable, and that's a major underdose, right? We need those 12 sessions over 6 weeks supervised. The supervision is necessary and key because that's our wheelhouse, giving feedback to the patient and helping celebrate wins with them, helping make sure their form is good, and then just that accountability to do the exercise. And one thing that's important too, you heard me say, we're great at addressing range of motion impairments and strength impairments, but we also need to have a mix of cardiorespiratory fitness on board in our sessions. And then the therapeutic exercise I already spoke to needs to include strength of the quads and glutes, but that in combination with a third thing, we need to focus on performance aspects, something that makes the human perform well in their world. So if it's getting out of a chair, you need to work on a power dosage and helping them get in and out of the chair. Or if it's going up and down the steps, you need to be working on overall performance of that activity as well. So if we're going to do exercise well in this population, we need to have the proper duration and dose, and you have to have three aspects: cardiorespiratory fitness, strength of quads and glutes, and then some kind of performance based activity. The final third piece of the puzzle of promoting anti fragility in people with knee OA, with humans with knee OA, is education. And I would argue it might be our greatest opportunity and our greatest probably challenge when we're treating those with knee OA. And it's in educating them on a few things. So I'm going to unpack that. And is that, and I really, I'm sure a lot of you are doing some of this in the clinic, but our number one strategy in education is really reframing the pain experience, writing a new narrative that for the patient, that their pain is not a death sentence to getting a um, knee replacement, that it's not a direct result just because they're aging, that they're automatically going to have decreasing wear and tear on their knees. We have a big goal to really reframe some generational and societal thought viruses, right? Janet, that's been told by her mom that her grandmother had bad knees and her mom has bad knees and she has bad knees, she just assumes that that is an inevitable genetic predisposition. And so I challenge us to reframe that bad knee narrative, or it's just because I'm old narrative, that ageist narrative, that you have knees, Janet, that need to be stronger, or that need more proprioception, or hips that need to be stronger to support your knees. And that little reframing starts to sharpen that pain map for the better, starts to reframe how Janet thinks about her knee. And that little shift is powerful. So it's not even just reframing about how that individual thinks about their knee, but it's also about their focus, and in particular how they address being physically active, because I told you we have to get them physically active. They have to meet those physical activity guidelines, but we really have to tie it to something that's important to the patient. In particular, we often see patients coming in, they sit down that first eval, and this is a tough moment, but they're usually like, I know I need to lose weight. My doctor said I'm fat, I'm obese, I need to focus on losing weight, and then my knees will feel better. I I say to Janet, you know what, Janet? No, that's not what I'm going to focus on in here. And I'm going to tell her we're going to focus what's called a weight loss neutral strategy. I'm not going to tell Janet that, but I'm going to, in my head, say, you know what's better to focus on, Janet, is focusing on getting your cardiorespiratory fitness and physical activity level up and your strength in your legs, not on weight loss, because they've heard that from their primary care, then they've heard it from the orthopedic doc. And that is not what they need framed in when they're trying to combat pain and when they're trying to increase physical activities. So we need to highlight instead the benefits of physical activity and resistance training in helping increase energy, increase overall fitness to play with grandkids, improve muscle growth, improve mental health, which helps reduce anxiety and depression. And then some of the other intangibles like confidence in self, confidence in going out with family and friends, going to play bingo, confidence in their movement pattern, to get in and out of a chair and to take a walk to the mailbox, confidence in those daily living strategies. Um, that is really our goal and our job when we're educating an individual, that we reframe things that they've been taught kind of their whole life societally about age, and just their overall knee health. And that's a really tough job that we have. And we can't do it all at once, right? But I promise you that if you have those three parts in your care, physical activity, meeting physical activity guidelines, 30 to 60 minutes, 5 days a week, that you create an exercise program that addresses impairments for that patient, both knee locally and hip. And then you hit that duration of at least 12 sessions over 6 weeks. And if you can make it 12 weeks, even better, because that longer duration seems to be what's best for helping this population. Then you're going to make change. And then that education piece just puts it all together and reframes it to empower the patient. Why this three-step strategy is magical and the only way to actually make it impactful for your patients, the only way to make it work, this magic formula I speak to, is you have to show them that all those things are true. That show me moment. It's not our patient's job to know they're getting better. It's our job to show them. It's not our patient's job to know that physical activity helps them. It's our job to show them. So when we do a high intensity bout of cardio on the bike, say 3 minutes, and then we rest 90 seconds and we do 5 bouts of that. After that, guess what? We're going to retest Janet's range of motion in her knee. Or maybe we're going to retest Jed's blood pressure that's been high. Or we're going to retest just how gait feels. And that magic moment where you show them that, wow, that bout of physical cardiorespiratory fitness actually did improve range, or it did improve fluency of gait or ease of gait. Or you take the time when Janet comes in next session to ask her about, how did those 6 bouts of 5 minutes go? How did you feel in your knee? And Janet's probably going to say it was tiring, a little annoying, but she'll also say, it's a little easier to get out of bed in the morning. I felt a little looser in my knee, a little less joint sounds. But those magic moments where you check in, that test retest is the only way to make that three-step program work. How do we promote anti-fragility in humans with knee OA? The magic three-step formula, the physical activity accessibility. Get your patients to a point where they can achieve that 30 minutes, 5 days a week for the powerful anti-inflammatory effects and the improvement in overall mood and confidence and competence in movement strategies. Start small, build them up. It's a lifestyle fix, not a quick fix. 2, you need to have exercise planning that involves strength and flexibility, training that addresses individualized impairment and helps modulate symptoms. And then our education piece has to empower and reframe that narrative of the patient and help them negotiate speed bumps, help them negotiate flare ups, and really help show them how that all three of these are going to help combat the effects of knee OA. That magic through the test retest in not only objective but subjective things each time you see that human is really the magic of the 3 steps in treating knee OA. Thank you for your time this morning. I hope you'll join Mark, Alan, and I on the road for extremity management, where we'll discuss in detail manual therapy and exercise dosages for humans with knee OA, and to learn more about how to dial dosage for those humans as well. Cheers to that 3-step magic. Have a great day, everyone.